Thanks, everyone. As per the introduction, I head up the OHS and wellbeing team at Northern Health, so I'll be presenting a case study from one of our sub-acute sites with a bit of an OHS lens, and going on from a lot of the discussions that we've had this morning. We know that aggression is spread right across the work environments in healthcare, and sub-acute is not immune to that. So I'll push on. Oh, the other down button, thanks. So I'll be talking about Kath Atkinson Wing, which I'll refer to as KAW from now on. It's a 15-bed secure geriatric and evaluation management unit at our Bundoora site. So we've got 5 sites at Northern Health, and this is located in Bundoora. So it's spread. We share the site with Melbourne Health. They've got a mental health component to the building. Our part of the building is sort of spread across 2 wings, and I'll show some photos shortly for some context. One wing being nominated as a high-risk sort of area, and the other wing being low risk. So they're all single rooms. In the high-risk area, the single rooms have got their own ensuite, and the low-risk share ensuites. The average length of stay is 30.5 days, and the patient cohort are those patients with behavioural and psychological symptoms of dementia. So we see a lot of difficult behaviours, a lot of intrusive behaviours, patients that are agitated, a lot of verbal and physical aggression as a result of that as well. So the model of care aims to maximise the patient's strengths and to embed a person-centred care approach. So a lot of diversional therapies and so on as part of the care planning. So the admission criteria there, so a diagnosis of dementia and comorbid conditions that require behavioural assessment and management. We do see the majority of the patients are 65 plus with delirium and behaviour management issues, but we do have occasionally patients below 65 years that are referred by ACAT with other behavioural management issues. So an example there might be a younger patient with younger age onset dementia and Down syndrome, for example. So the patients come directly admitted from home, residential care, acute care, or from other subacute care. So some photos for context of the site. So it's on our Bundoora site, which is a nice sprawling sort of site with plenty of natural light and gardens. As you can see there, the bottom photo is the back of the KW unit. So we've got access to a garden there. There's a little gazebo and a bus shelter, and that's used frequently in the warmer months. But obviously at this time of year, it's not that welcoming to be going out there. I guess it's important to note that this unit was not built for the purpose of which it's used right now. So it's not a fit for purpose facility, and that's you can see that that's quite clear when you look at the internal photo there. There's a lot of hard surfaces. There's a lot of noise that bounces off those hard surfaces. So it is quite loud. And when you're dealing with patients with the types of behaviours that I've described and the sorts of conditions that I've described, you can see that that could lead to issues, particularly with the noise and that increasing agitation, and that's certainly what we find in KW. So a little kitchenette area there as well, which can be used for diversional therapies and also by the staff. So this data is all OHS, OC violence and aggression incidents reported across Northern Health since June 2015. So you can see there a steady increase across the organisation. We're the same as every other organisation in that underreporting is a problem for us. What I would say though is that KW, which is top of the list there, has a really good reporting culture. So 1/3 of our OC violence and aggression incidents reported across all of our sites come out of this 15-bed unit, more than our emergency department, which is the busiest in the state. So we've got a great reporting culture, and I think that's probably due to a number of things. It's probably due to the work that we've done with the team to encourage them to report, and starting to see some tangible improvements that I'll be talking about shortly. and a really good culture of teamwork in that unit as well, that they look to support each other and report these incidents. So we do sometimes see multiple reports of the one incident coming through. So if anything, there might be some over-reporting, but I think if anything, it's probably accurate to what we would see there. And obviously for all those other areas across our different locations, quite underreported. So my team about 2 years ago started working with KAW quite closely to better understand this aggression and what we could do to help them to address it. We started with some staff safety perception surveys. So this is, this is a survey that you'll find in the WorkSafe guidance material, and some alarming findings. So 50% of the staff telling us that they did not feel safe at work. 74% of the staff telling us that they did not feel sufficiently prepared to manage aggression or violence at work. 50% telling us that they were that they perceived to be experiencing aggression on a weekly basis, and 88% telling us that they believed that we could improve the work environment to better manage aggression and violence. So clearly from some work for us to do as an OH&S team and together with the local team there and site management to improve. So in terms of the risks that we identified as a result of the staff safety perception data and also working with them in focus groups, there were plenty of risks that we identified both to staff and to patients. So we were seeing an increase in aggression and violence. This was physical harm, it was hair pulling, it was pinching, it was behaviour that was verbal as well. Self-harm was a concern, and also absconding risks with the patients. So this was leading to understandable distress amongst the patients, their family and our staff. And the cumulative effect over time was obvious as well, that it was really having an impact on the staff in terms of that vicarious trauma over time as well. So we're seeing increased absenteeism as a result. We were seeing an increased likelihood of staff injury and the human and financial costs that are associated with that. And we're having difficulties in retaining and attracting skilled staff to work in the space. So not a good place to be in, and plenty of work for us to do. So we worked with the team to better understand what does it look like for them if there's 88% of them are telling us that the work environment could be improved to better manage and prevent aggression. Well, what would that look like? So we did some consultative risk assessment with them, and up on the slide there is what we call a bow tie assessment. It looks kind of convoluted, but it's a fairly basic risk assessment approach in a focus group context with the staff. So in the middle there you've got the hazard, which is aggression in KAW, and on the left-hand side there you've got the contributing factors that lead to that aggression. So broadly we categorise them into three main areas of environmental, human and clinical contributing factor areas. And then on the right-hand side you've got the consequences. So if the aggression does occur, then what do we see as a result? So we see staff injury, we see patient injury, we see potential workers' comp claims and the financial costs and so on. So in the middle we have the risk control. So these are the things that we've got in place to manage the aggression and prevent it from occurring. And the items that are in blue there are the things that we identified as having in place. So they were risk control measures that were there at the time, and this is going back 2 years now. The blue boxes with the orange borders are those things that we identified as having in place but perhaps weren't up to scratch, benchmarking with across the sector and looking at the literature. And then the orange boxes are those things that we didn't have in place at all to really work on. So this approach allowed us to prioritise with the staff what would you see as being most effective in addressing these risks, to allow us to put an action plan together. So then on the other side you've also got the consequence control. So should the aggression occur, what have we got in place to mitigate this risk from being as bad as it possibly could be? And the sorts of things that we saw there, portable duress alarms, EAP, peer support and so on. So in terms of the environmental risk controls, you might be, well, you're probably all aware of the department funding that started a couple of years ago for infrastructure and capital works. Doing this work allowed us to put a case to DHHS for that violence prevention fund, and in particular the equipment and infrastructure work. So unfortunately we weren't successful in the first round, but very pleased to say that we were successful in the second round. So thanks to the department for reconsidering our application there. And the work that we did leading up to that application, particularly that consultative risk assessment approach, allowed us to put a really good case together. So the sorts of things that we were able to implement, and some of this is still yet to come, were, from an environmental risk management perspective, we looked at sound absorbing surfaces. So looking at the literature, we knew that noise and high stimuli was really leading to increased agitation and aggression. So if we could manage the acoustics in the environment, both in the public spaces and in the bedrooms of the patients, then that would help to manage the aggression. So we're installing sound absorbing surfaces in those spaces, so on the walls and in the ceilings, putting a new dividing wall in the common area, so between the high and the low risk areas, so that we've got a bit more management and separation of those patients. A roller shutter grill in the ward kitchen, so a space that our staff can go to in the event that a patient is becoming violent, that they can have a space that's safe for them. And managing light and privacy. One of the things that was raised as part of the risk assessment approach was the issue that we had around windows and curtains being pulled off the windows by agitated patients, that was resulting in those curtains sometimes being used for self-harm or harm to others as well. So if we could better manage the lighting, that would lead to better sleep, obviously for the patients, and privacy as well. And obviously the cost of replacing curtains was becoming quite a problem also. So we looked at double glazed windows and also internal curtains between the windows, so that the staff could better manage the light for those patients who needed that managed for them. And also looking at our duress alarm system, so upgrading that so that it went back to a central command centre, and having on-person duress alarms for each staff member. So these are just some of the risk controls. There was a whole bunch of other stuff that we did that's non-environmental, so looking at improved training arrangements as well, and competency-based training in particular. We did have an online package that had been implemented in years gone by, but we really needed something that was a bit more robust, and that's been rolled out over time also. So coupled with these environmental risk control measures, it's a broad approach to managing the risk. So just by way of example, that's a makeshift improvement to one of the windows that we did have. And here we have the new windows that have been installed with the internal blinds, so quite a significant environmental improvement. We're also partnering with NARI, so the National Ageing Research Institute. They're doing both pre and post intervention evaluation with us. So using some structured tools that are up on the slide there, they'll be looking at qualitative and quantitative data to assess the success of the interventions that we've applied. And we'll be looking to get that published as well. So be keen to share that across the rest of the sector, I'm sure, once all this has been rolled out. But as I was saying, some of those environmental risk controls are still yet to happen, so this work is currently underway. So we'll be looking at our incident data, we'll be undertaking those staff surveys and continuing to work closely with the staff in this space to improve our processes for managing aggression. Thanks.